the Recurrent Miscarriage Matters, Evidence to Inform Policy and Practice. We have 3 speakers and experts with us today. I'd like to introduce Professor Keelan O'Donoghue. She's a consultant obstetrician and subspecialist in maternal fetal medicine and a senior lecturer at Cork University Maternity Hospital. She is the National Women and Infants Health Programme Implementation Lead for the National Standards for Bereavement Care following pregnancy loss and perinatal death. And she's the National Women and Infants Health Programme's clinical lead for guideline development. Keelan established and leads the award-winning Pregnancy Loss Research Group. Joining Keelan is Dr. Daniel Newsom. He is a lecturer and researcher at the Pregnancy Loss Research Group with a particular interest in the impact of miscarriage on men. Daniel serves as a healthcare chaplain at CUMH and completed his PhD on the spiritual and professional impact of stillbirth. And Marita Hennessy is also joining our speakers today. She is a senior postdoctoral researcher and experienced health services researcher in the Pregnancy Loss Research Group, and she has a particular interest in dissemination and implementation science. So thank you so much to our 3 speakers for joining us today. I just want to take this opportunity for everyone attending this webinar to let you know that this content some may find particularly upsetting or triggering. There will be supports shared at the end and during this presentation, but just to have awareness of your well-being throughout this, and feel free to leave the conversation at any point. So I'll kick off to Keelan O'Donoghue. Keelan, if you would be so kind to start the presentation.
Great. Thank you very much, Mary and Aoife, for that introduction, and welcome to us, where we are based on the UCC top floor of Cork University Maternity Hospital. And we're going to talk to you about recurrent miscarriage matters, sharing with you the evidence from Ireland to inform our future policy and current practice. As Aoife acknowledged, in this webinar, we're going to discuss topics that people may have direct experience of and may find upsetting or distressing. We are sharing some details of where to get support, and we'll share that around with you afterwards again. There's a lot of information in these slides, and we're not going to go through all of it, but it's also that the slides are for your reference and that you will be able to share them within your task force, and we'll be able to come back to them and use them again. In today's talk, we're essentially going to go through, I suppose, 3 sections. Firstly, dealing with recurrent and miscarriage themselves, talking about the causes of miscarriage, the risk factors, investigation, treatment and outcomes. Secondly, the second part of the talk is about our current service provision, where we have some positives, but also need improvements in our care approach. And finally, we're going to share with you an evidence-informed model of care to ensure that people receive a standardised, equitable, accessible and adequately resourced service.
Hi everyone. So the presentation is primarily going to be based around the Recurrent project, which was a national evaluation of recurrent miscarriage services funded by the Health Research Board. It provides a significant body of evidence to to inform decision making and practice. And while it is based in an Irish context, it also fills significant gaps internationally in terms of what we know and what needs to happen in terms of services regarding recurrent miscarriage. We have used integrated knowledge translation throughout the project, so involving key knowledge users from the start. And just to acknowledge our steering group and our research advisory group, and also our research participants, and we'll acknowledge them at the end also.
So today we are presenting to you the programme of work from the Recurrent Miscarriage study to draw out what we consider to be significant findings. And while there is some good practice nationally, which we wish to acknowledge, we do need to standardise our practice with a graded approach and dedicated resources. And to do this, we have 6 main recommendations to propose to you, and we will cover. Here's the slide, please. We will cover each of these areas during the presentation this morning.
So I'm going to fill you in a little bit about the background information around miscarriage and recurrent miscarriage and why this matters. Miscarriage is the most common complication of pregnancy. Around 1 in 4 pregnancies end in miscarriage. You'll see that statistic used across lots of reports in Ireland, but actually that's completely made up from a rough estimate of the number of births in Ireland per year. We don't record miscarriages in this country like other countries. The pooled risk of miscarriage would be about 15% of all recognised pregnancies, and if you put that on a global scale, that is 44 miscarriages per minute. The knowledge of the risk factors for and causes of miscarriage is poor. We've shown that in our own research in Ireland, showing that a fifth of respondents in a big national Ipsos poll believed miscarriage only occurred in 0 to 5% of pregnancies. As you'll know, and some of you are involved in, the National Maternity Bereavement Experience Survey is specifically not dealing with miscarriage. But as part of the scoping around that work, this report from HICWA does say that capturing and reporting accurate data on all types of pregnancy loss could help raise awareness and inform healthcare planning and practice. Recurrent miscarriage, what does that mean? So that's a controversial or different decision across different countries and in different guidelines. Traditionally, the old-fashioned definition is that it is 3 consecutive pregnancy losses in the first trimester. But there's always a little bit of difficulty around, are they preclinical? Do you have to get to a scan? Who diagnoses that pregnancy loss? And are they consecutive losses or not? And if we were to look at population prevalences in terms of what this means, and this is relevant when we come to talking about clinical practice and models of care, about 10% of women will have had 1 previous miscarriage and around 2% 2 consecutive miscarriages, with just less than 1% having 3. There are a number of risk factors for and causes of miscarriage and recurrent miscarriage. These are I suppose, listed for your information, and we won't have time to go through all of them, but they include demographic and behavioural and environmental risk factors, as well as fetal and then maternal clinical risk factors. There are a number of investigations that can be done to investigate recurrent miscarriage, but not all of them have a sound scientific basis behind them, and they're not backed up by evidence. And as part of this project, we've synthesized international clinical guidelines, and as you've heard, we are producing a national clinical guideline on recurrent miscarriage to provide some, I suppose, correct standards around the investigations on the left, which are considered appropriate and lead to a benefit if their result is treated, and the investigations on the right, which can be done and frequently are done in the private sector or internationally, and which have no evidence behind them. The Lancet series on miscarriage, which you're going to hear a little bit about throughout today's webinar, looked at all of the information as well, published in 2021, and these are the 4 essential tests that they came up with based on a review of all of that international evidence as to the 4 tests that have a basis and that are essential to investigate recurrent miscarriage. Similarly, and this is of relevance to, for example, as some of you will know, the National Genomic Strategy, which is coming out of the HSE, there are recommendations around genetic testing in pregnancy loss. So analysis of the pregnancy tissue is a key test for 2 and for 3 miscarriages, and parental karyotyping, so parental chromosome testing, will also sometimes be both recommended and required, bearing in mind at the moment that there is no genetic laboratory in Ireland which is providing these services. Similarly to investigations, treatments can be divided into those that have an evidence base and those that do not. And this vulnerable patient population are, I'm afraid, very much sometimes directed towards treatments that don't have good evidence, that can potentially have a high cost and sometimes have risks associated with them. So you'll see at the top supportive care, which is one of the few treatments of recurrent miscarriage that actually has an evidence base around reducing miscarriage and subsequent pregnancy, but the number of proven medical and surgical treatments is currently quite limited. So we do end up in a scenario where a number of miscarriages remain unexplained. The prognosis, though, for future pregnancy can be quite good for many women, depending on their individual risk factor profile. And as I said, various studies show that attendance at early pregnancy clinics in future pregnancy has benefits. And we know from the literature, and that's why we use this quote, which I think is quite powerful, that what women want is a plan with one doctor who shows understanding, takes them seriously, has knowledge of their history, listens to them, gives information about recurrent miscarriage, shows empathy, informs on progress, and inquires about emotional needs. And that should be the gold standard. The other reason why miscarriage and recurrent miscarriage is very relevant, and this is really poorly understood and accepted among the medical community and the obstetric community, unfortunately, is that recurrent miscarriage is a sentinel risk marker for future pregnancy obstetric complications, including really serious ones like preterm birth, abruption, and stillbirth. And it is also a predictor of longer-term health problems such as cardiovascular disease.
We know from the published literature that miscarriage is associated with a significant psychological burden as well. And these symptoms range from those associated with what we might call a normal grieving process to those associated with complicated grief, including post-traumatic stress. And for some, these symptoms fall within the range of the recently agreed definition of prolonged grief disorder in the text revision of the DSM-5. So it's reasonable to assume then that with recurrent miscarriage, these burdens might increase. Recurrent miscarriage also has a considerable financial burden. We found that on average, women spent a combined average of 3,250 hours off from work to attend for recurrent miscarriage care appointments. And it also had an impact on the workplace, with 70% reporting decreased productivity at work. The financial burden on women was increased with travel expenses and other out-of-pocket expenses, some have just been referred to, related to additional services, scans, and in a number of cases, expensive fertility treatment. Now, this didn't include additional domestic expenses, if you will, such as childminding or allow attendance at appointments. And these are areas which can actually all be addressed. Looking now at the overall health-related quality of life in recurrent miscarriage, on average in our study, women scored low on the mental component summary of the health-related quality of life index, indicating the likelihood of women experiencing depression, with 50% falling well below the population norm. This is not an inconsiderable impact. Miscarriage also impacts on men, and we know in the global published literature and supported by our own Irish study that men struggle with how they are cared for and their experiences of feeling excluded or unimportant in recurrent miscarriage care. They also struggle with the difficult balance of grieving themselves on the one hand and yet trying to stay supportively strong on the other for their partner. And men have also reported how with successive miscarriages, it is harder to form a bond with their baby. And yet again, a number of these impacts can be easily addressed.
Now we're moving into the second section of our talk, and we're going to talk about recurrent miscarriage care in Ireland, what we've learned from our study, and sharing with you our conclusions that while there are positives to build on, improvements are needed. The first of those is how we define recurrent miscarriage, and this matters. And this is something, as I've mentioned before, that is a little bit contentious internationally, or has been until the last couple of years, where people are standing back and looking at it again. There has been a convenient use of an old and outdated definition that to meet the criteria for recurrent miscarriage, a woman had to have 3 consecutive confirmed first trimester miscarriages. And we know that how we define miscarriage and recurrent miscarriage in particular does shape both the experiences of care and the services that are received. Up to now, stakeholders' views have received relatively limited attention, and it's fair to say that the definition we set, which is being recognised by many other countries other than ourselves, does reflect both the medical evidence but also the values of a society at that time.
So how are we, or should we be defining recurrent miscarriage in Ireland? In the next series of slides, I'm going to draw on findings from our qualitative interviews and also our service evaluation. So on the right-hand side there, you'll see details of the 62 people that we interviewed across the country regarding recurrent miscarriage services. And I suppose just to draw your attention to here, we included men and women with lived experience of either 2 or 3 consecutive miscarriages, just to see who may be included or excluded from current service provision. And we were also interested in the spectrum of health professionals and allied health professionals who work across both secondary and tertiary care, because often, as we know, in terms of early pregnancy loss, people don't come into contact with hospital services. It can often either be just at home or they might attend their GP. I'm also going to draw on the service evaluation in which 18 of the 19 units across the country completed surveys for us. So I suppose, firstly, in terms of what the service evaluation told us, there was variation in the guidelines used across the 18 units. And I suppose looking there in terms of the majority draw on the UK guidelines, who use a definition of 3, and then about half also draw on the European guidelines, which is a definition of 2 miscarriages. And there's also people who kind of adapt guidelines and have local guidelines in practice there. And I suppose this then is very much reflected in what you see in terms of how people within services define recurrent miscarriage. You can see the majority still define recurrent miscarriage as 3 or more, and then under half define recurrent miscarriage as greater than or equal to 2. And then within that, I suppose there's less variability in terms of whether a pregnancy has to be confirmed or whether it's biochemical. But interestingly, and we'll discuss this a little bit more in terms of the qualitative research, pregnancy losses like molar pregnancy, pregnancy of unknown location, and ectopic pregnancy, there's lots of diversity in terms of whether people include that or not in terms of the definition. And then I suppose drawing from the interviews with the 62 key stakeholders, we identified 3 main themes from these interviews, and I'm going to go through each one of these in turn now. Just to note, I do include some quotes. We have so many quotes and they are so rich, and it really shows the power of qualitative research. I'm not going to read them out as I go through, but you'll be able to see them on screen and you'll have them available in the slides afterwards to look back over them as well. So just in terms of the first theme, so health professionals stress the need for and benefits of an agreed definition of recurrent miscarriage nationally. The definition of recurrent miscarriage was commonly framed within the context of referral criteria, with many health professionals stressing the need for these criteria to ensure that those perceived to benefit the most from the service would be seen. While it felt cruel and unfair to enforce strict criteria or refuse people for appointments, they perceived that this was better than giving people false hopes, increasing stress levels and unnecessarily prolonging time to subsequent pregnancy. Clinicians and those in management generally felt that recurrent miscarriage should be defined as 3 consecutive miscarriages, with exceptions made for those who are older, did not have any living children, or those with fertility issues. Some health professionals, however, and men and women with lived experience thought that recurrent miscarriage should be defined as 2, given the psychological and emotional impact on them and the possibility of delaying potentially beneficial interventions. Several issues rose when discussing how recurrent miscarriage is defined. This extended beyond the number of miscarriages, as we saw on the previous slide, to individual characteristics such as age, number of living children, fertility issues, as well as such issues as whether they were consecutive or not, if it was a biochemical pregnancy or not, and gestational age at the time of loss. Many also acknowledge that the costs and other resources often limit the number and type of staff who could be seen or investigated for recurrent miscarriage. And while women and men appreciated the cost as a barrier, they felt they could be better supported. In terms of our second theme then, the way that recurrent miscarriage is defined is important for couples beyond access to the system. It can be their way to finding an explanation or meaning for their loss and potentially realising their dreams of becoming a parent. All spoke about the impact of recurrent miscarriage on women and men, as Daniel has outlined. And women and men search for answers as to why their miscarriages happened, and sometimes source things online which have questionable credibility. Many spoke about how investigations could provide reassurance, but may not always provide the answers that they were looking for. And many participants also spoke about women and couples feeling frustrated and dismissed when denied investigations, particularly after 2 miscarriages. And this was often exacerbated when health professionals highlighted how common miscarriage was, or how often it was down to luck or chance. And many highlighted that there's a gap in the service for those who are denied investigations, a lack of follow-up or support, and a sense of being left in limbo. So our final theme then, some health professionals spoke about advocating on behalf of women or couples when they didn't meet the specified referral criteria, or attempting to get around the criteria when it was 3 consecutive losses, to ensure that women or couples received the care that they needed. This tended to be appreciated by couples who perceived that their needs were being met, but a few clinicians highlighted that such advocacy efforts might not often be in the best interest of women or couples and could do more harm than good by raising expectations or putting them through unnecessary testing or delaying time to pregnancy. Many spoke about people turning to the private sector if denied entry to the public system, whether they could afford it or not. And I suppose this is a really important consideration going forward in terms of sláinte care and delivering a service based on need and not ability to pay. Some health professionals, particularly clinical midwife specialists and sonographers, alluded to moral conflict inactively but covertly encouraging women to seek private care. And many participants highlighted that the private sector was seen to have less strict criteria for investigation and more deviation from the rules.
So in summary, how do we close some of these cracks that Marita has referred to and that we have identified thus far? Well, we need a standardised definition of recurrent miscarriage. We need tailored care that is supported by an evidence-based with a graded approach to recurrent miscarriage care. And we're glad that this work has already informed the imminent, we hope, Recurrent Miscarriage National Clinical Guideline.
I'm going to take you through where current services and show you the varying service provision and care experiences reported in Ireland. And here we use we draw from 3 studies to examine how recurrent miscarriage care is currently both delivered and experienced in Ireland. So both the qualitative interviews that you've heard about, our National Care Experience Survey, and the service evaluation across the 19 maternity units. And what this told us is that while there is some good practice, for example, treatments are generally in line with key performance indicators, the variation was most obvious in referral criteria, the location of and access to clinics, the lack of availability of genetic counselling, the lack of access internally or externally to other members of the multidisciplinary team, such as counsellors, perinatal mental health support and psychology. And finally, almost no recording of subsequent pregnancy outcomes after recurrent miscarriage taking place within even the currently existing recurrent miscarriage clinics.
Yeah. And I suppose drawing from the learnings from the interviews with key stakeholders around how current services are delivered and how they're experienced by participants, there's kind of one line that can kind of summarise it all in terms of what is needed, and that's a standardised, dedicated and adequately resourced and supported service in which women and men with recurrent miscarriage are offered appropriate, individualised, timely and accessible care and support. And I suppose underpinning that are dedicated staff, dedicated space and time, and dedicated funding and support, and the need to prioritise recurrent miscarriage. So just bringing you through these 3 themes. So dedicated staff have specialist and experiential knowledge. Recurrent miscarriage can be perceived as an unattractive and unrewarding area to work in, however. All staff need ongoing training and support, and I suppose within that, the clinical specialists in bereavement and loss provide a lot of training to colleagues and other staff around the hospital, but acknowledge that they're stretched, well, it's actually both, it is, in terms of what they can do, and that need to balance staff training with providing supportive care to a vast array of patients with different types of pregnancy loss also. And I suppose within that as well, definitely across the interviews, it came out that there's an opportunity to better engage with primary care providers. While it was very much acknowledged that people who are based within tertiary services, and I suppose specifically dedicated recurrent miscarriage clinics, those people were seen to have the necessary expertise. But within primary care, it was seen that these are the people who are meeting women and couples much more frequently, who have established relationships with them and who can provide necessary supports as well. But they often feel ill-equipped in terms of their knowledge of recurrent miscarriages and what services and supports are out there. So there are some quotes, again, I'm not going to go through them. The second theme then in terms of dedicated space and time, and I suppose this is kind of relational and informational space and time as well. So this comes up across the board all the time in any type of research that we do around miscarriage, recurrent miscarriage, pregnancy loss, the lack of dedicated or appropriate spaces within maternity units and hospital services, the importance of giving time, but time is constrained due to competing demands. And I suppose this is giving time at the point of actual loss and giving the time afterwards at investigations, treatments, subsequent pregnancy care. So across the spectrum. And the need for non-judgmental, empathic, timely, accessible communication and information was also deemed really important. And again, often it was felt that when people are denied access to a system of care, they can often turn to the private sector, or they can go to Dr. Google and find lots of information about treatments and investigations which are inappropriate. So a lot of time in consultations has to be spent then kind of explaining things to people and resetting their expectations about what's possible and, you know, what's important for them in terms of future care. And also Daniel highlighted this earlier, this also came up, recognising the needs of both men and partners. And again, that kind of feeling actively excluded from services, but service providers themselves not really knowing how to engage men more within the process and within services. And just then, in terms of the final theme, so multi-level buy-in, collaboration, leadership and champions are needed. I suppose within this, it was often felt that miscarriage and recurrent miscarriage is often low priority. However, around the country, there are people working within services who are actively championing improvement efforts, but often they kind of reach a stumbling block when they're trying to get higher level support. And I suppose within that as well, it was acknowledged that women themselves with lived experience do a lot of work in terms of advocating for better services. Many highlighted across the board that evidence-based service change and delivery is needed, and I suppose this will help those advocacy efforts, because when you go to try and make change within a hospital, it's like, okay, what's the evidence behind that? How much is it going to cost? And I suppose this is where this project fills in, because we have the evidence and we have the costs. So that will be good in terms of moving forward. Funding is always needed, and I suppose it was recognised, that it was needed, and I suppose often services themselves were constrained by funding in terms of moving from having referral criteria from 3 to 2, and often services themselves drew on philanthropic efforts or fundraising efforts to provide kind of essential services for parents in terms of spaces and information resources and things like that. And I suppose the kind of underpinning thing across all of this, which is one of the major barriers to affecting change in this area, is the societal silence around pregnancy loss and how to engage in conversations, but it also affects people's levels of awareness and the information that they have around this whole issue and pregnancy in general. Again, some more quotes.
Needless to say, COVID was a particularly difficult experience for anyone accessing and availing of our maternity services across the board, and in particular for those who experience loss. And the already mentioned impacts were heightened for those who are experiencing recurrent miscarriage. And while COVID was very difficult, one of the challenges for us was that people who were providing particular support in recurrent miscarriage were very quickly redeployed to other services. And that's an area of concern for us, particularly when we think of our bereavement and loss midwife specialists, who in some cases were redeployed to other areas. And that does give a signal that perhaps that loss is not of high priority in some places, and that is a matter of concern. Now, while COVID exposed some of these difficulties, I'm sorry to say, but I think it's fair to say that what it did was it actually exposed what was already the experience for many people in recurrent miscarriage, and actually the focus on COVID just brought it to the surface. So it's not something that has gone away because we have moved on from COVID, but it has highlighted something that was already there for us. Turning now to our care experience survey, the data showed that we have work to do. We've work to do to get to optimal care and investigation, and indeed for these to be offered in a standardised and consistent way across our maternity services. And we highlight here on the screen some of the particular findings, but those findings are consistent across the data from our study. So when we looked at the overall care experience, the results reveal considerable room for improvement for women and for their partners. In many ways, the results on the screen just now highlight their experiences with us as professionals and their experiences of the system, so to speak. And once again, we should, but more importantly, we can do better. Just looking at one area now for a moment, the environment. As highlighted earlier in the data, it shows that much more can be improved. The results, interestingly, were almost identical for the experience in the waiting area that's on the screen, but also in the consultation areas. And these are areas that can be improved.
Yep. So I suppose in terms of what we've learned from the care experience survey and what's important, because we asked so many different questions, and I suppose in terms of prioritising what you would actually work on, this is what our analysis showed, that for all aspects of recurrent miscarriage care across investigations through to subsequent pregnancy care, women were more likely to rate a good experience if they had enough information, if they received answers they could understand, if they had a health professional they could talk to about their worries and fears, and if their partner could ask questions. And also women who received a treatment plan or those who were offered early reassurance scans were more likely to rate a good recurrent miscarriage care experience. And I suppose picking up on Keelan's point earlier around that care in a subsequent pregnancy in terms of reassurance scans, and that is what the evidence is also saying as well. Just to quickly note, infertility and recurrent miscarriage, our colleague Dr. Laura Linehan is doing some work in this area, and we will have lots of research to share on that in the future also. So I suppose taking all of the learnings from the different studies, what do we know about care experiences and service provision? So we know from the care experience survey that women report poor care experiences. From our interviews, we know that similar findings are coming up from the service evaluation. Provision across the country is varied, and there's lots of barriers and facilitators to effecting change. So I suppose the question now is, how can we translate what we know into practice and improve the care experiences of people who are affected by recurrent miscarriage across the country? And I suppose these findings are not new. Similar experiences have been reported since the 1980s. But I suppose there is hope and there is opportunities for us. There's opportunities through the National Maternity Strategy, which outline provisions regarding people who experience pregnancy loss and specifically talk about women with recurrent miscarriage. So there's an opportunity to build on that and to implement that through national action plans also.
So we have provided the evidence to inform a model of care for recurrent miscarriage, which should ensure that people receive standardised, dedicated, equitable, accessible and adequately resourced service. What we know is that there's wide variation in recurrent miscarriage practice. There's a call, not just here, but internationally, for improved care and high quality research. And what we see is that care for recurrent miscarriage couples is often overlooked, and as Daniel has mentioned, it is the first to be deprioritised. So we're not alone in looking at this, and there are approaches suggested for standards of care around recurrent miscarriage, which other countries are also looking at and potentially adopting. So you either go with the traditional model where there is minimal or no care until you've met the artificial criteria of 3 miscarriages, or you adopt a certain sort of a model of seeing people after 2 with limited investigations and then full after 3, or you take or you look at a graded approach to recurrent miscarriage care. And you've heard us mentioning that before, and essentially that's to ensure that there's a basic level of care and information about miscarriage for any woman who has 1 miscarriage in our services, both in primary, secondary and tertiary care, and that is escalated after 2 and 3 miscarriages. So we know that the definitions are changing internationally, and we must move with the times in that regard. Our work shows us that we should individualise care according to women and their partners' needs and preferences, that we should define a minimum set of investigations and treatments, and that physical and psychological support needs also need to be at the heart of this programme of work. So you'll see in the table how we've set out what would happen after 1st, 2nd and 3rd miscarriages, with across the board women being given information, answers and supportive healthcare throughout and after pregnancy loss, and ways to optimise health for future pregnancy. When we're talking about a dedicated recurrent miscarriage clinic, which would be after 2, something that could be run by a midwife practitioner with support, and at 3 miscarriages from a consultant with a special interest, the consultant-led clinics would provide dedicated and focused services to women and couples with standardised and agreed national referral criteria, with a set of recommended investigations and subsequent treatment options, and also providing information and psychological support to women and couples in that regard. And we do have some of these clinics nationally, but not certainly operating in any kind of a standardised format and not having access to the full breadth of the multidisciplinary team. This project has also included some work to cost implementation around best practice models of care for recurrent miscarriage clinics, looking at what would happen if women were seen after 2 and after 3 miscarriages, looking at setup costs for those clinics and ongoing implementation costs. We're not going to drown you in that information, but it is something we can talk about and share more with you. But we've looked at initial setup and implementation costs for these clinics, as well as what it would be to manage a typical or a complicated patient through those services. And these costs include staff time and different numbers of staff involved, as well as investigations, treatments and scans and care into the future pregnancy.
So if we look for a moment at what we have before we begin to anticipate what we need in this area, first of all, we have a robust evidence base now from our Recurrent study highlighting all the areas that we've shared with you this morning. And there's also a growing public and professional interest in the overall area of pregnancy loss, including many champions around the country, and we include you in that, and leaders locally and nationally. And that, of course, is also the case internationally, and some very invested people in various ways, not least our own pregnancy loss research group here at University College Cork and Cork University Maternity Hospital. A significant gain for us in recent years, though, and both Keelan and I have been involved with the Perinatal Bereavement, National Bereavement Standards since their inception, has been, first of all, the existence of the standards and their subsequent revision earlier this year, but also the appointment of bereavement and loss midwife specialists in each of the 19 maternity units in the country, with the caveat we really need to not lose that and to hold on to that considerable gain for us. They are critically important roles in each of our services, so our points earlier on about how they could be redeployed does send a signal and is something we would want to highlight. So that's what we have thus far before we go, and we're delighted that the recurrent miscarriage clinical guideline will be coming soon. So that's what we have before we move on to what we would like.
So what we need.
What we need. What we need.
And I suppose this is from now. What do we need right now based on what we know of what's happening around the country and what people's experiences are like? So we need to prioritise miscarriage and recurrent miscarriage, and I suppose that comes out very strongly within our research. Even though we talk about recurrent miscarriage, is it 2 or is it 3? For everyone, it starts with their first loss, and that informs their subsequent care and experiences. So it's really important that we look at recurrent miscarriage within the context of miscarriage also. Yeah, a bit excited there.
Right.
All right.
Okay. Whoa. Sorry, folks.
Yeah.
Small degree of control meltdown there. Yeah.
Yeah. Okay, so we need a standard definition.
Oh, goodness. Very annoying. Go on, keep going.
Yeah, so we need a standard definition and care pathways. As both Keelan and Daniel mentioned, we have a new national clinical guideline on the way, but it's not good enough just to have a nice published document. We need to actively implement that, and that will require adequate resources and support. We need a minimum service for couples with recurrent miscarriage in all units around the country. So that would look like a dedicated clinic regionally. So we're looking at maybe about 9 hospitals, and there would be a midwife and consultant-led service within all units, and that is around providing care coordination and also continuity of care, and a dedicated research centre with cross-disciplinary expertise. We also need dedicated staff. So within the standards that have been mentioned already, that provided for bereavement midwife posts across the country, but I suppose from our research, both the service evaluation and the qualitative work, it's clear that often these posts are unfilled, or people move within posts, or during COVID, these were moved out of posts into other areas. So it's really important that posts are filled and also they are sustained, so people are supported in their roles, provided adequate training and support for staff. We also need dedicated staff staff or midwife for miscarriage within all of the hospitals. As we mentioned, it's important to see this in terms of miscarriage also, and they will ensure care coordination and continuity of care. In terms of improved laboratory and genetic services and support for implementation of the new genomic strategy. We also need pre-pregnancy counselling and psychological supports for couples with recurrent miscarriage, and I suppose that's looking at it integrated within services, not relying on services outside of the hospital or that couples might have to pay for as well, because there's an equity issue there. And we also need standardised reporting of miscarriage and recurrent miscarriage, even though it's so overused, but what measures counts, so we need to kind of start collecting that data. And I suppose underpinned by all of this and all of the work is that we need to actively collaborate with people with lived experience of recurrent miscarriage regarding their care and service improvements. It needs to be based on their needs and led in that way.
So in summary, what needs to change for recurrent miscarriage care? We should prioritise and standardise recurrent miscarriage care, and we would propose a graded approach after the first and then subsequent miscarriages. There should be an improvement in dedicated funding and resources, that is, for a service for all the units around the basic approach to miscarriage care, should I say, as well as a specialist recurrent miscarriage clinic service. We can and should enhance supportive care and informational support. We do need better care coordination between ourselves in the hospital sector and our community care colleagues in general practice. Part of this is also enhancing education, training and support for health professionals, and to really work on, as a lot of our work in this group advocates for, an improvement in public awareness to help break the silence and stigma around all forms of pregnancy loss, and specifically here miscarriage. What next for our work? We must first acknowledge that the HRB have funded this project considerably for 3 years to the end of this year, potentially into a few months of next year as well. And we have just been, this is still not official, but we have just been awarded a further grant from the HRB to work on knowledge translation from this project. And that gives us the resources to develop and disseminate tailored information resources for women and men, to help develop online resources, and to co-produce resources with many of our collaborators across the Recurrent project in a variety of formats. So we're not done yet. So in summary, I suppose what you've seen is 3 parts to this talk, talking about miscarriage and recurrent miscarriage and why it matters. Summarising that while there are some positives, there are many improvements that are needed to standardise our care approach. We've given you the evidence to inform a model of care for miscarriage and recurrent miscarriage nationally, to ensure that there is an equitable, accessible and hopefully better resourced service into the future. So thank you very much for listening to us, and hopefully that has been of both use and interest to all of you. And we obviously have time for questions, and we'll put back up some of the main slides to, I suppose, help maybe direct some of those questions appropriately. Okay, over to you.
Thanks so much. Thanks, Keelan, Daniel and Marita. That was a very interesting presentation. We have asked for questions in the chat box of this meeting, and some are already coming in, so we'll just dive into those. So does your research highlight any cultural or ethnic diversity factors which might be relevant to future policy development?
Yeah, do you want to take that, Marita?
Yeah, I suppose definitely in terms of the qualitative work, a few things came up, and I suppose in terms of how we define recurrent miscarriage, it often came up in that context, in terms of often services will put an age criteria. So if a person is aged over 35 or up, that they would be seen after 2 rather than 3 miscarriages. And I suppose people acknowledging the issues around cultural differences in terms of age when people expect to or are expected to have a pregnancy. So issues around that. Also issues arose regarding the need for interpreters and translators within services themselves, you know, having them accessible.
Yeah. And there is almost no information available about miscarriage, and what there is relatively outdated and not based on any of the current literature or guidance.
Exactly.
So even if you're English speaking, the literature is poor.
Yeah, it's very poor. So yeah, in terms of within services and staff, and then also information resources that are provided, they would be the main ones.
Yeah. And that's where our subsequent, our follow-on grant, which we will start, we will start at the end of the year. That's where the follow-up work is going to try and provide better information resources, but to make those inclusive and diverse in who they're reaching, I suppose.
Definitely.
There's a question here about the full dedicated service you had referred to, and just referencing the recruitment challenges currently faced by the health service. Have any recommendations? Have they provided enhanced support during a transitional position?
Well, I guess firstly, what we're talking about here is not rocket science, you know. There are relatively limited investigations and relatively basic treatments, and an awful lot of what people need and what makes a difference is to get the right information, to have a healthcare professional who is interested, who cares, and who hopefully is knowledgeable and expert in their attention to recurrent miscarriage, and they want to get support in a future pregnancy. None of this is beyond the ability of the current services as they are structured. We do have resourcing for at least one bereavement midwife CMS in all 19 units. Those individuals are hard to train and keep and sustain, and we have lost some of those midwives across COVID. But what we would propose is that those midwives would be involved in the specialist end of the service for the more complex cases with, say, the consultant like myself, who's specialised in this area. And that what we would try and achieve is a basic level of care across the 19 units with a staff midwife who works within the bereavement team, and a doctor and a senior clinician who takes the lead for pregnancy loss and provides the backup and information. And none of that is impossible for us to achieve. We have perinatal mental health teams resourced throughout the maternity hubs, but they specifically are not resourced or obliged to see cases, to see miscarriage cases. They're specifically focusing on later pregnancy issues. So we have a lot of the pillars of this already. It needs to be prioritized. And like everything else, when it is seen as a priority and a limited amount of resources put into it, lo and behold, changes happen. So apologies, but that is a particular soapbox of mine, as you might have guessed. but it's not impossible. It is absolutely not impossible for us to achieve this. There are clinicians like myself who have plugged away running these services with absolutely no support or attention. For many, many years, the clinic here was established before I started 15 years ago, and I've continued to develop it. There are 9 units that have a consultant who runs a recurrent miscarriage service, but very tightly controlled referral criteria and very tight tram lines, I would say, not guidelines, about what they actually do. So we do have the interested people, and I would argue that there isn't a single healthcare professional in any of our maternity units who doesn't have direct, unfortunately sometimes personal or family or professional experience of miscarriage. We're not talking about something that's difficult to train or to do. In terms of advanced midwife and nurse practitioners, sorry, I just see that question coming in there and it's related. Absolutely. I'd be hoping that what I talked about, the first step, so after one miscarriage, there's a requirement that everybody gets supportive information, gets pointed in the right direction as to what happens next, and gets care in their next pregnancy and somebody to talk to. After 2 miscarriages, you'd very much be going towards a potential nurse or midwife practitioner with the overarching supervision of a senior clinician, of a senior medical clinician. And absolutely, and there's no doubt that our bereavement CMSs, the bereavement CMSs that I work with here, run clinics on their own for that current level, and then the doctor or the person with the extra specialist skills is involved in those who are looking after 3 miscarriages, or those who fail. I mean, I have women in my clinic with 15 miscarriages, and we have some people who make it and some people who don't, but we do have a complex population. We also, as you know, have a population that's aging. If we look at the Indigenous Irish population in terms of the age of first pregnancy, and we do have a complicated, I suppose, skew towards late 30s and early 40s in terms of those presenting to our clinics. So this demand isn't going to go away, and if anything, it's going to increase.
Keelan, just on that model of care and aligned to that, I'm just curious, and as well referencing the deprioritized care due to other health priorities.
Yeah.
In your experience and your evidence, is there any indication as to where in the community patients would like to receive care and what type of care they'd like to see closer to home as opposed to in current settings?
In hospitals. I suppose when it comes to 2 or 3 miscarriages, you know, it is the hospitals who really need to provide these services. And again, it's not beyond our ability to do so if you look at the range of social work, perinatal mental health and bereavement services that have been provided to the maternity hospitals. And there's no reason that can't be done. At the moment, we do tend to refer to, we sometimes refer to external counselling, but there is there's no public service for that, so people end up paying. And if people are self-referred out to counselling services in the community, we know that they don't go into they don't go to people necessarily who are specialised for their particular needs, and that can do much more harm than good. I mean, our primary care colleagues would certainly, I suppose, like to have more resources from that point of view. But again, for the majority of people, we're not talking about complicated needs. There are women who are very complicated medically or who have multiple miscarriages, but the vast majority don't. They're not, you know, they need information, support. They need to meet somebody who cares. I won't say what I normally say when I'm lecturing to colleagues and students here, but they need to meet someone who, you know, shows them empathy, who listens, and who gives them the right information and points them in the direction of the correct online resources. And that's what our follow-up grant is aiming to do, is to help people help themselves as well, rather than us saying we need to resource absolutely everything everywhere for everyone.
And empathy and caring is it kind of rings true to the whole Women's Health Action Plan. It's not just, we've heard it many times.
You know, that people, you know, if people feel if pregnancy loss is acknowledged as and it is acknowledged that it has an impact and that it is an issue, that's part of the battle solved.
And just to say, that's very much backed up by the qualitative research as well in terms of men and women when they talk about it, but often they either don't engage with their GP or aren't engaged by their GP because there's a level of discomfort and a lack of awareness and education. So I think there's definitely a role for engaging primary care practice nurses as well as general practitioners and public health nurses. There's a real appetite there. They want to be engaged, but like that, it's kind of around signposting information and support, and women themselves are like, we want the specialist, we want the dedicated, but we need to be able to have the conversations and ask questions of our GP as well.
A question, do these recommendations also have bearing for women who have had recurrent experiences of fatal fetal abnormalities and how to seek abortion and had to seek abortion care for this?
Well, that's a whole other webinar, Aoife, and I'm not quite sure if you want me to get on my soapbox about that one.
We can maybe schedule it.
There are projects in this group on every aspect of pregnancy loss. We have a project at the moment on molar pregnancy. We've looked at ectopic pregnancy. We've obviously done a lot of work on stillbirth, and we are just submitting our final paper on parents' experiences around diagnosis of so-called fatal fetal anomaly, with those who continued and those who ended their pregnancy equally reflected in that work. So again, what comes out of all of the work we do around pregnancy loss is the actual importance of the healthcare professionals that people meet, and whether those people are knowledgeable, are expert, whether they listen, whether they care, and whether they are consistent in their care approach, and obviously continuity of care. And I suppose it's fair to say across all the work we're involved in, and if one of you wants to jump in, but across all the work we're involved in, whatever the type of scenario of pregnancy loss is, that's the consistent theme, that what we do and what we say as healthcare professionals matters. And you can't always change, well, you can almost never change for people, that's another webinar, but you can never change for people really what the outcome is when you're faced with that outcome or that diagnosis. But you can absolutely change their experience of care and the impact or otherwise that has for their next pregnancy and for their long-term health.
Yeah,
absolutely.
Yeah, I'd agree, and that definitely is kind of reinforced in the qualitative research. It's the impact of recurrent miscarriage, but it's the impact of the service when you have recurrent miscarriage as well. It's that double.
Yeah.
Daniel, I'm curious just on the silence that you discussed and the engaging in society on this issue. There's a gap, a significant gap there. Anecdotally, we've heard miscarriages and recurrent miscarriages as an unidentified grief, and particularly in your experience as healthcare chaplain, in perinatal loss and palliative care. I'm just curious if you have a view of how policy can help to legitimise the grief aspect, and how we can encourage society to engage in this more.
Yeah, absolutely. It's hugely important, and I mean, we find it very difficult to speak about it. So in terms of policy, even what we're doing today, you know, is talking about grief, talking about loss, and it is for many people seen as a disenfranchised loss. You know, it's not very important. A complete lack of understanding around attachment, around connection, around all the other markers of grief and bereavement. And also, it's fair to say, in terms of our social circles, our occupational circles, I think we can say we're looking at this in terms of with another department, government department, around workplace conversations and supports around pregnancy loss and early pregnancy loss. I mean, for both men and women and men, and often it's true to say that people haven't shared the news of their pregnancy, and then they experience miscarriage, and it's quite difficult then to tell somebody, I've had this particular loss, I haven't even disclosed that I'm pregnant. So it's a complex one.
But I guess our research across all types of pregnancy loss, and we've done work with Ipsos over the years on both fatal fetal anomaly and stillbirth and miscarriage, shows that the Irish population, while generally a well-educated population, are not, and I'm sure you know this from all your other areas of work, are not particularly health literate in terms of understanding. And even if you were to do a little search across, and here's another soapbox, even if you were to do a search across your various websites and to go across the Health Services Executive websites, you would see that there is not entirely the correct information about what pregnancy loss is, or how common it is, or how much it might happen. So we have a big piece of work to do around all types of pregnancy loss to put it kind of on the agenda as something that happens. I mean, miscarriage particularly is the most common thing that goes wrong in pregnancy. And when you think about the amount of investment that we put into things that are at a 1 in 1,000 or a 1 in 100 level, it makes no sense not to certainly focus on miscarriage. We have a bigger argument, I suppose, in this group when we talk about stillbirth and later types of pregnancy loss, which are experienced by a much smaller but equally important number of women and men, that there's a complete societal silence around those later pregnancy losses. And very much talking about it, putting it on websites, making it the subject of webinars like this, putting it out there in the hospital, holding our services of remembrance, getting staff to attend those services. We have Baby Loss Awareness Week coming up in 2 weeks' time. Putting notices about that at the front door of the hospital to make everybody aware that this is a common and shared problem. So there's a whole piece we need to do as a society, but obviously those of us in our individual areas of responsibility can achieve quite a bit in this regard.
And the litmus around that is how often parents say to us, we never realised how common this is.
Yeah.
It's almost like this whole new world opens up in front of them, and they realise they've friends and colleagues.
What our work is showing, that if we don't do this properly, and it's very consistent, I'm quite sure, with many of the other areas of health that you're dealing with, all of you, if we don't deal with this properly in the public sector, we are referring people to an incorrectly audited and a private sector that does not work on evidence, science, or guidelines. And that is not helping all of our population, and it's certainly an increasing problem that we see in terms of the vulnerability of this population.
And people who can't afford it.
And people can't afford that, obviously, yes.
Well, Keelan, Daniel, and Marita, thank you so much for this presentation, and thank you everyone for your questions. It's been so insightful, and I just wanted to remind anyone on this webinar who needs it, there will be supportive links shared with you. It is in the chat already, but they will be emailed around as well. If anyone has any questions that they didn't get to ask or come to them later in the day and would like to get some clarity, please send them our way and we'll try our best to get you an answer. But again, thank you all to all our speakers for your work and your dedication to this area. It's greatly appreciated, and thank you for sharing the knowledge. I'm going to hand back to Mary now to conclude the webinar.
Thank you for giving us the platform to address you.
No, as Aoife said earlier, actually, you're so much in tune with the Women's Task Force and listening to people and empathy and getting in. And that's what we hope to do this morning. We got the information out there. Thank you so much to the three of you. And thank you, Aoife, as well, actually. And thank you to everyone that joined. I know a few people had to pull up there in the last few minutes, But again, it just shows we could go on and on with the questions and everything in this. It is recorded. It will be sent out with the presentation today as well, with your PowerPoint, to all the task force members and to the Department of Health as well. So we will. And you never know, Keelan, I think by the sounds we might be back again. You know, it was so interesting. We might be back to the three of you again.
Sorry, please. I might just all my stuff.
Yeah, thank you so much. We're a great tag team there, the three of you. You know what I mean? Brilliant.
There's lots of other members of this group and of this research team, and we certainly are happy to share our knowledge and information gleaned from the last kind of 10 to 12 years of research, for sure.
Well, that's brilliant, because we're here to get the information out to people as much as we can. So thank you so much. And again, I will send out the links to everything. And again, the support groups as well, the support links will be sent out with the PowerPoint and with the video as well later on the week. So thank you, and thank you everyone for joining.
Thank you very much.
Bye. Bye. Bye.